Okay, so welcome to the knowns and unknowns of myopia management and other cool stuff in optometry. This is brought to you by the American Academy of Orthokeratology and Myopia Control, as well as GP Specialist. GP Specialist is 100% dedicated to OrthoK and has one of the world's largest portfolios of OrthoK lenses. We thank them for their support. And I'd also like to say thank you to Contact for underwriting a portion of today's program. Optimum is one of the most popular lens materials in the market. All right. So before we get started, I also want to add that the opinions and viewpoints expressed tonight do not reflect the AAOMC or the sponsors of this program. And this is episode 5 of our ongoing 6-part series. And we have 2 sections for tonight. Our first section is a panel discussion, the role of ophthalmology and optometry in advancing pediatric myopia management. And then after that, we have a clinical corner featuring Dr. Leah Johnson and Mark Consgrove. All right, so I'm going to go ahead with the introductions. We'll have our panelists turn on their cameras and their microphones. And I'll go ahead and introduce our first panelist. So representing the ophthalmologist perspective, we have Dr. Will Key. Dr. Key is a board-certified ophthalmologist who practices both adult and pediatric ophthalmology. He completed his undergraduate studies at the SUNY 7-year BS-MD program and was awarded his MD at the Mount Sinai School of Medicine. Thereafter, he completed his ophthalmology residency at NYU School of Medicine, where he was selected as the executive chief resident. He then completed his fellowship in pediatric ophthalmology and strabismus at Washington University School of Medicine in St. Louis. After being employed in a private practice in Long Island for more than 15 years, he left that practice to start his own in Queens. He's been involved with myopia management for the past 8 years, using a variety of modalities, including atropine, OrthoK CRT lenses, and now MiSight multifocal contacts. His diverse background and practice experiences brings a broad perspective to the management of ocular diseases of all ages, especially myopia. He also has an MBA from NYU Stern School of Business and is an assistant professor of ophthalmology at NYU Medical Center and Northwell North Shore University. Dr. Key, wow, welcome to the program.
Thank you so much. What a great introduction. Thank you.
All right. And next we have Dr. Cary Herzberg representing our optometrist perspective. Dr. Herzberg has been in practice for 51 years. He completed his Bachelor of Science Degree and his Doctor of Optometry Degree from Illinois College of Optometry in 1969 and 1971. Dr. Herzberg is a leader in the field of contact lenses, a member of the advisory board of GPLI. Dr. Herzberg is a past president and founder of the AAOMC, as well as the current president of the International Academy of Orthokeratology and Myopia Control. And he recently joined J&J's PAC team as a speaker and consultant. Dr. Herzberg, welcome to the program.
Well, thanks, Matt. Dr. Key, it's good to be here.
All right. And I'm Matthew Herzberg, the executive director of the American Academy of Orthokeratology and Myopia Control. I'll be your host and moderator for tonight's panel discussion. All right, so to start things off, I want us to get to know these 2 doctors because I feel like there's been such bad blood in the past between ophthalmology and optometry, but now myopia management seems like it could be this focal point that brings these 2 groups together. And I'm wondering if we're getting closer and closer to that moment in the teen 80s movie where we're at the school dance and we have ophthalmologists on one side of the gymnasium. We got optometrists on the other. They're awkwardly looking at each other. The music starts playing, and the rest of us are waiting to see if these 2 start dancing because I think you all have a lot in common, and this could be the beginning of a beautiful relationship. All right. So before we get started, I do want to add that both of our panelists tonight do actively work with both ODs and MDs. All right. So first, what is your experience with myopia management and how did you get into it? So Dr. Key, I want to start with you because I already know a few things about the other guy on this webinar. But I'm wondering, how did an ophthalmologist like yourself get into myopia management?
Yeah.
So why don't you tell us about your experience practicing myopia management?
Yeah, sure. It's interesting because, you know, as an ophthalmologist, we learned about OrthoK back in residency. I think there was like a paragraph in one of our books, and it just mentioned it briefly. It just kind of mentioned, you know, it was done way back when, It didn't work really well. There was a lot of complications, and you can just forget about it. It's just good to mention it. And that's what exactly I did. I forgot all about it until, and I honestly can't remember exactly how it came up again. I don't know if one of my patients were asking about it, or one of my optometry friends were kind of mentioning their experiences with it. And it just got me curious, because I do a lot of laser vision correction. I thought, wow, I don't have anything to offer my pediatric patients. What a wonderful option for them. Yeah. So, it's funny, I think these two opposing kind of like groups, they might not get together at the prom, but they may get together at church. So, in the church is where you have the football player and the chess geek, and they're both like actually having coffee together. So that's where I met my optometry friends, and they introduced me to it, and they were really generous with their knowledge and their experience, and I gradually learned about it. And I noticed one of the attendees is Dr. Jonathan Cho, and kudos to him. He's the one who actually really taught me a lot about it. So I give him a lot of credit for kind of getting me comfortable, and he's always been there when I had any questions. So he's been a great asset for me, and so he's definitely earned my respect.
That's
but
awesome.
I started kind of with just a few patients. I started with the best patients, my own family. That's the best place to start. So my nieces and nephews were my first patients, and then my first professional patient was in Long Island, was a 12 or 13-year-old who was a high-level competitor in sport karate. And the interesting about that is that you're allowed to wear your glasses and you're allowed to wear your sport goggles, but you're not allowed to wear contacts. So with him, he thought that the goggles interfere with his peripheral vision, so he wanted to have another option. I thought, let's try it, and he did great. So just fast forward, I just saw him probably about 2 or 3 weeks ago. He's in college. He's doing great. He's still doing OrthoK, and so it's been very successful. And honestly, throughout the years, it's just been, as the technology has improved, I'm getting much more comfortable with recommending it, with prescribing it. So it's been very, very positive.
That's awesome. Thank you for sharing that. Dr. Herzberg, some of that sounds familiar, doesn't it?
It does.
Passionate, looking for new technology to help the patient. Whereas Dr. Key got into it more recently compared to yourself, you're part of the pioneer generation of orthokeratologists. So tell us a little bit about your experience practicing myopia management.
Well, it began for me, Matt, back in the 80s. And we were looked at as having horns and a tail at that time. The devil made you do it kind of thing. What were you doing to the cornea, right? And it's not that we ran into resistance. We ran into a massive resistance to this. Not just from ophthalmology, ran into it from optometry too as well. It was, for whatever reason, it hasn't been embraced like it should be, because as Dr. Key was reflecting on this thing, it's got some marvelous things it can do for patients, and it's a wonderful alternative, to a young patient who can't do LASIK yet to be able to do OrthoK then. Not to mention the control of myopia, the management of myopia, which makes a better LASIK outcome because it's not as myopic. So it's just a win-win everywhere. But listening to what he has to say here, it's like, this is like nirvana. I've come home, after all this long journey of the desert. I feel like Moses to the promised land here, and all of a sudden we're here, and am I allowed to get in now, or do I have to go away somewhere and do another 40 years somewhere out in the Sinai desert or something? So, this is pretty amazing to hear, his experiences. Yes, they sound very familiar, and they're common human. These are doctors. We're all doing this thing, and who are doing this thing. You'll find that just the advantages of it are just amazing.
Yeah, oh, go ahead.
No. I just said I agree wholeheartedly.
Definitely. Optometrists have been doing myopia management, myopia control longer, primarily through OrthoK. And you're right, Cary. I was at meetings and I would talk to optometrists and I would say, "Do you do any OrthoK?" And they'd be like, "Why would I do that?" So you've definitely heard it from both sides for sure. I don't want to beat up too much on the ophthalmology side of things, but I feel like optometrists have gotten very used to pushback from ophthalmology here in the United States. But you're the president of the International Myopia Control Group. Have you seen a different story in the rest of the world? That's what I want to know.
It depends on where you're at. You know, if you're in like the US is one who've been reflecting. Also, Western Europe is very similar to the US as far as ophthalmology is concerned. When you go into Eastern Europe, however, it's a whole different country. They're actually ophthalmologists are doing all of that. They're actually practicing optometry, and we couldn't be happier about it. Russia, there's 3/4 of the countries that I go to don't have optometry. So if it's going to get done somewhere, it's going to be ophthalmology that does it, and they are embracing this thing, and it's a pleasure to go and work with them. And you know, see this come together for them, and again, a mutual experience here to Dr. Key's experience. So, you know, you go places like Romania and Russia. This is it. This is ophthalmology driven. So it really depends on where you're at. South America, different parts of the continent. In Brazil, they're mostly done by this is done by ophthalmology. But in Colombia, they have one of the strongest optometric institutions in South America, if not the strongest. So they are leaders down there, amazing people. You can go around in China. It's amazing. They've grown an optometric profession. They've actually seen it grow up because ophthalmology realized there that, you know, a lot of these things that they want to do with myopia management is best done through optometry. You know, I mean, sure, they can do all these things, but really their focus is in surgery and other things. So it's not really that appropriate for them, for most of them. So they saw the need for optometry, and they've grown it there. You know, medical optometry now is an amazing thing to watch at that point. And then to be in Vietnam, to see the first graduation class of optometrists. You know, 45 optometrists graduating at that point in Vietnam. That was an inspiring moment for me in a country where you have like 75 million people, 80 million people. You got a 75% myopia incidence. And then you have in the country, when we began really reflecting on it, we're like 2 pediatric ophthalmologists that were doing this. And you know, it blows your mind, you know, as far as what needs to be done there. And so now they're doing that, you know, and this is a story you're seeing worldwide. So it's as we've been reflecting, it's not ophthalmology or optometry. It's taking care of our patients, right?
Exactly.
Yeah.
So, Dr. Key, do you agree with Dr. Herzberg? What is and should be the role of optometry and ophthalmology in reducing myopia progression globally? What do you think?
Yeah, I think that we both have a deep responsibility to not neglect it, and it has to be acknowledged and it has to be dealt with. So whether it's been done by an optometrist or an ophthalmologist or both, it doesn't really matter. I think at the end of the day, I mean, I think it should be done by people who are proficient, and for those who are not proficient, they need to know the network of people that they can refer to. And I mean, I think it's less important who does it as opposed to how it's done. And I guess to me, the kind of like the adoption, the widespread adoption, as long as it's being ignored, it's, you know, people are going to suffer from it.
Yeah, and I'm also reminded that, you know, ophthalmology here in the States has been historically resistant to myopia management, specifically orthokeratology. I was wondering if you could speak on that a little bit, like where did that come from, and how do we get more ophthalmologists like yourself into myopia management? What do you think?
Yeah, I think most ophthalmologists have a biased view of OrthoK because, you know, patients who are doing well usually don't go see their ophthalmologist. It's patients with keratitis, with pain, corneal abrasions. So that's all they see. And, you know, when I talk to my ophthalmology colleagues, a lot of them are just telling me, you know, just nothing good. I've never heard anything good from any of my ophthalmology colleagues. They all tell me how it's bad, shouldn't be done. It's kind of reflective of how, you know, when LASIK first started coming out, people were really against it. They thought it was malpractice. You know, nobody should do it. And even before that, when we're doing cataract, it's like, you know, phacoemulsification was bad. Don't do it. You should be doing extra caps. So I think eventually ophthalmologists will be more accepted, more open to the concept of doing OrthoK and other modalities of myopia management, just because they have to, just because we know it works. And I think the success speaks for itself.
You know, never well said, Dr. Key. I can remember back when the local cataract surgeons brought his kids in to my practice for OrthoK for myopia control, and his colleagues thought he was out of his mind. He said, "What are you doing? Are you crazy?" And it became then the choice of taking care of his children's vision and even overcoming, right, the things that he had heard and then doing that. I was really proud of him and what he had done. And I did ask him to come practice with me too, but he said, I can't take the parents. He said, the Asian parent is just difficult for me to deal with. I'll continue with my cataract surgery specialty, but yes. Yeah.
I mean, I've certainly heard my fair share of optometrists say something to the effect of OrthoK should remain the domain of the optometrist and don't let ophthalmology get his hands on it. Dr. Herzberg, why are they saying that? And I mean, how do you feel about it?
It's silly. It's just, it's like, there's someone's like in the desert, he's needs something to drink, and right next to him over that next hill is this giant freshwater lake. It's like that, because there's just, there's no need for it. I mean, this is something that's to be done by everyone who wants to do this, really. I mean, we should be sharing all this as much as possible. It's not an optometric thing or an ophthalmology kind of thing. It's for, it's for our patients. It's a skill we have that we can do wonderful things for our patients. And I disagree with that totally. I think this is, if you want to do this, go for it. I think, and it's not one thing or the other.
Right. And go ahead.
Sorry, I want to add on to Dr. Herzberg's words, and I think that was really well said. I think at the end of the day, who's proficient at doing whatever they're doing should be doing it. It doesn't matter what their title is. I think the other thing is, the more people that do OrthoK, the more it's just going to grow. So, I mean, there are so many patients, so many myopes. What are you fighting about? You don't have enough office time to fit that. You're going to fight each other and just, you're going to kind of block each other from getting patients. Just everybody can kind of support each other, and together, I mean, the growth will be exponential.
It'll be special. Yeah.
Yeah.
Right. And Dr. Key, I mean, I have a feeling that both sides are experiencing similar entry problems when it comes to adopting myopia management. So from an ophthalmologist perspective, what are the most intimidating factors, and how do you overcome them to starting a myopia management practice?
Yeah, I mean, first of all, when I first started with this, I was clueless. I had no idea what I was doing. So that's a major barrier. But I think, there's so much, resources online, and there are colleagues that one can talk to, and there's podcasts such as this that, one can get very familiar with this topic very quickly, and particularly with hands-on work. I think, for ophthalmologists, for pediatric ophthalmologists, we have a pretty heavy volume. Like, I don't market my myopia management. I get one patient after another. I get, 5 or 6 patients an hour, and it's not a selling thing. It's just, this is what's available, and it comes from the heart. I sincerely want to make sure that these patients have the options that are available to them that can help them. So what they choose is up to them. These are their options. I'm there to support whatever decision they make.
Right on. All right, so let's do like a side-by-side comparison. When it comes to myopia management, Dr. Key, we'll go back to you for a second. Are you presenting myopia management to all your pediatric myopes? And if not, what's preventing you from doing so?
I present to everybody. Yeah, I present to everybody. I'll even start talking about it when they're like 4 or 5 years old. I might not start prescribing lenses at that age. I might not start giving pharmacological therapy at that age, but I'll start to speak about it, and I'll talk about, what kind of strategies to start them off early. I even start patients on atropine when they're borderline. So if they're somewhere between 0 and plus 25, I actually start them on atropine therapy to prevent the onset of myopia. So I believe starting early is key.
Dr. Herzberg, do you agree with that?
This is awesome. This is listening to Dr. Key here is just so awesome. I start with the moms. In fact, the pregnant mom.
Well, I can't beat that.
We're going, this is a total dedication to myopia management, right? And so I like Dr. Key, I present it across the board. It's my first choice. It's the first thing on my mind when I'm looking at that situation. And even when I have a parent in the chair, and usually the mom, is the first one, and talking about their family, you know, what's going on. That's where we make the inroads into it. And talking from a optometric standpoint for a moment, you know, when you're doing myopia management, you're doing it on kids, right? You have to build a pediatric practice. So talk to the parent, the mom, and let them know what you're doing and your interest in that. And that's how you start building this pediatric practice that, you know, we're talking about here. So you have to begin at that point, you know, having kids in your practice, which is a choice. Yeah.
Definitely. And I'm glad you brought up kids specifically in that context, because Dr. Key, if I'm not mistaken, correct me if I'm wrong here, but I think I remember in our pre-show conversation, you had mentioned that, you know, with some ophthalmologists, there is, you know, they only see the worst cases or effects or side effects from like an orthokeratology case gone wrong. And there's a lot of hesitancy around children, you know, fitting lenses on children. I mean, in Dr. Herzberg's case, I know he's fit kids as young as like 4 or 5, right? Is that right,
Yes,
Cary?
that's correct.
You know, so how do we get over that hump? Because I feel like that's one of our biggest obstacles, is that we have a set of optometrists who are focused on fitting kids, yourself, fitting kids. So how do we bridge that gap then for ophthalmology? What do you think?
Yeah, I think first of all, I think that fitting OrthoK is a big responsibility, and I think it should not be done in mass. I think each case has to be very closely supervised. I think the younger they are, the more you have to supervise it. And should there be any complications, manage it. And if you can't manage it, speak with the pediatric ophthalmologist or a cornea specialist right away. Don't wait until they have to work their way into finding another doctor if there is a complication. So I think as the kind of the positive and not the negative come in, I think that's going to work itself. I think a lot of ophthalmologists would be, you know, less fearful of kind of advocating for it.
Yeah,
And
we are.
I'm
sorry. Go ahead.
Yeah. Secondly, I think you know, for me, I think it's important to emphasize not just the functional benefits of myopia management, but the long-term medical benefits of myopia management. Because as ophthalmologists, we just, you know, a lot of ophthalmologists trivialize refractive errors, but it's not simply a matter of refractive errors. It's has to do with macular degeneration, retinal holes and detachments, you know, LASIK outcome. So these are investments for the individual's future, and you know, that's not trivial. I'm so sorry. Please.
No, please. I'm sorry. I was just going to comment that I see referrals now from clinics that you know, I said hell will freeze over before I see a referral from a clinic, you know, an ophthalmology clinic, and sure enough, hell is frozen over. I get a lot of them now. So I see the turn, you know, right? We see that happening now. Yes, yeah, quite a bit.
I'm glad you brought that up, because the next topic I want to cover is it possible for us to co-manage between ophthalmology and optometry? And I guess we'll start out by saying, like, is there any one modality for either side that works best or is more favorable to them? Cary, I know that orthokeratology is like your bread and butter. You do it all, but like your OrthoK component of your practice is very robust. In your opinion, is there one aspect that's specifically suited to either side? What do you think?
Yes, LASIK. It's this. We're doing similar things to the cornea. You know, what's really awesome about this is that in China, we have LASIK surgeons who are fellows of the OrthoK Academy over there. So they do both things. You know, you talk about the future. I mean, these doctors are just, you know, they have the whole thing there, right there. So they're doing it. Yes, LASIK. We work quite closely with our LASIK centers that we refer patients to, and we do. And OrthoK leads to LASIK beautifully, because the patient doesn't want to wear glasses or contacts when they're older. They want to have freedom, you know. So they make wonderful LASIK cases. So this is a natural. It's just like develop these relationships, because they're right out there just waiting to happen. And the LASIK centers send us the pediatric patients, you know, who they find that you know, they're not ready for LASIK yet. So yes.
And Dr. Key, I know you're, you know, largely in favor of MySight. We talked about that in the pre-show. Do you recommend that MySight be a great entry point for ophthalmologists and optometrists?
I think it's great. I think a lot of people are intimidated by by the OrthoK, the RGP lenses. And frankly, we don't have, ophthalmologists have very little experience with hard lenses. So having like a medium that is familiar and we think it's relatively safe, it's kind of a very low barrier to entry. Plus, in addition, there's very little chair time compared to OrthoK. So I think it's a perfect entry point. And then from there, I think thinking of other options like OrthoK and different types of OrthoK would be a perfect complement to using my site.
My site, I mean, we owe them how much thanks for this. I mean, they got this through. I was in near Washington when they attended the FDA conference about, myopia management, whether that was going to be something that's going to be in control at that point, that something was going to be approved or not. And my site has done all the work, and we looked at that when we went to that conference, and we looked, when is this ever going to happen? They were right. They were open to it, but it was it was going to be kind of that mountain to climb. But here is, Cooper Vision that went through this thing and got the myopia control. I didn't think I'd see that in my lifetime. When this thing came through, we were over in Europe, right? And we were at the Europe meeting, and they were all there. The Cooper, we were hugging and dancing up. It was like this most amazing thing. So absolutely, I agree totally with that assessment. That is an incredible thing now available as a tool for us.
And Dr. Key, do you agree with Cary about, LASIK being the perfect co-management opportunity between the two sides, or is there more opportunity? What do you think?
Oh, LASIK is great opportunity, because I think for us, the highest margin in our business is LASIK. But we also want to, I think, to reach out to the pediatric ophthalmology community, because a lot of them are not employed in a practice who have LASIK surgeons. So I think for them, I think it's a good idea to always have some kind of exchange with patients. I think it's a healthy exchange. It always works. I remember a long time ago, I had lunch with a colleague who worked in a medical center, and he was saying, he was going through the whole list of all the patients I could refer to him. And I said, well, what about these pediatric cases you can refer to me? They're like, oh, no, I can't refer any patients to you. I have to refer within the group. So I'm thinking, well, let me get this right. I got to refer all these patients to you, and you're not going to refer any patients to me. Yeah, I don't think that's going to work. I think, in order to have any kind of trade, in order not to have a deficit, you have to have communication, and you do have to send patients back and forth. We should not be territorial.
Yeah, Cary, I mean, I've heard from some optometrists who have a difficult time getting into myopia management. There's this aspect of, if I refer myopia management patients, I'm basically just giving away that patient. Would there be a similar concern, do you think, between optometry and ophthalmology in this case?
No, I really don't. And I think that's, that if you have like Dr. Key's talking about, you have that kind of relationship going on with them as professionals. I don't think there's an issue with that. If there ever became an issue, we would address it immediately, obviously. So we don't see that in our relationships at all. They're very straightforward in what they do, and it works very well. Yeah.
Agreed. One of my colleagues has an optometrist in his office, and he sends all his OrthoK to his optometrist. So there's no issues there.
Excellent. All right, so let's talk about some unique strategies for practicing myopia management. So let's start with you, Dr. Key. In your practice, what have you found as far as what's working for you? What's a unique strategy that you could recommend to other ophthalmologists and optometrists?
Yeah, I think because I see both pediatric and adult, I kind of focus on the medical implications as an adult with myopia. And, luckily, a lot of my patients, I work with a lot of Asian patients. And, to say the least, wearing glasses is common, in this community. So I think they recognize that, they've been through the trouble of wearing glasses and dealing with contact lenses. And many of them had laser surgery themselves. So they're kind of familiar with this problem. And then adding on the other complications, including macular degeneration and retinal complications, I think I find it to be very useful and honest too, because I'm not trying to kind of push any ideas. I'm just telling them what the facts are and things that they already know. And, the opportunities that were not available to them are now available to their kids. So it's up to them whether they want to do it or not.
All right. And Dr. Herzberg, what about you? What kind of unique strategies are you implementing in your practice?
Well, you have a total commitment to managing the myopia, and what we get is the parent that brings the child in, and the parent got nearsighted when they were in middle school or even postgraduate education, and their parents were farmers in China. Let's say, I see a lot of Asian patients too, and the kids are now sitting in my chair, and their prescription is equal to or higher than the parent's prescription, and they're worried. So I find the biggest benefit I can give them is to take that worry off their shoulders. I mean, we give them that sense that we're going to do something about this and take care of this. And God, Asian parents worry about everything with their kids. I mean, totally from top to bottom, right? So it's like, I tell them, I'll put that on my shoulders. If I tell you ever that it's time to worry again, I'll tell you, otherwise let me handle the situation from now on, and you relax. We're going to take care of it from now. So I think the biggest benefit I can is to take them off the edge, the window edge there where they're going to, that they're at that point.
Yeah, for sure. And I'm also wondering about, like, what is it going to take for, myopia management to go mainstream then in that case? Because, and I think it was Dr. Despeditas that pointed this out on an episode of The Corrective View, where he said, and I've also heard him say this on stage, but, he said before there was a myopia epidemic, before there was a pandemic even, there was an obesity epidemic. That's something that everybody understands, and yet this is still a problem. I think there's a lot of pressure from optometrists, and Dr. Key, I'm wondering if ophthalmologists have this same issue where it's like, I think there's that need to barrage the patient with the severity of the situation. And there's obviously different cultural concerns, between Asian patients or other kinds of demographics. So, what is it going to take for this to go mainstream, I guess, is what I'm asking. And Dr. Key, what do you think?
It's my opinion that it's already happening. I think it's growing organically. When I first started doing myopia management, it was kind of like, oh, really? Like, they've never heard of it. Now people come in asking for it because everybody knows somebody in this area who's doing some form of myopia management. That includes atropine too. They've heard of atropine. And they haven't heard of MiSight yet, but I think soon enough they're going to hear about that too. I think the second thing is that the responsible kind of usage of this technology is really important. So I think as the safety increases, where the benefits outweigh the risk, then I think you're going to get more widespread adoption. And then thirdly, kind of somewhere on the first point is that it's just a networking externalities of this. The more people who are involved in this, or more patients that are having some kind of myopia management, the more that it's going to grow just by word of mouth.
Cary, do you agree with that?
I think I've been around for a while, so I've seen a lot of different trends. I go by I have what I call the 20% rule, which basically means that 20% of the doctors do 80% of what's done in that field. So I think this is going to be a specialty. I see maybe dabbling in it by a lot doctors doing one case in a while, it's something like that. But I think there's going to be like 20% of us that really take this on and really become quite specialized in myopia management. And those 20% will do most of we'll get the referrals, other things that will happen. It's actually a really good story for all of us, because it means that, growing now in our field, and as Dr. Key pointed out before, profit margins are huge here. Making a profit fuels what a doctor can do with their practice, and we live in the age of these VCPs now that are really reducing benefits to as far as fee reimbursements. This is good news, right? This is a good news story.
Absolutely. So. I think, the reimbursements are not getting any better. And I think, there's just a limited amount of time in our days. And I think part of the communication is it worth it to do OrthoK or other sorts of management? And if you bring together the benefits, the functional benefits, the medical benefits, and, even the financial benefits, is it worth one's time, communicating, getting that point across will kind of help increase the adoption of myopia management.
Absolutely. agree totally on that.
Definitely. Through working with the AAOMC, I find myself in contact with a lot of optometrists, working with them. And we run into this problem often where a lot of optometrists dabble. And I think that's a very reasonable thing to understand, right? This is a very intimidating prospect to get myopia management started in their practice. And we try to impress upon them the idea that they need to go all in. And for some reason, it like Cary Herzberg is my father. Spoiler alert on that, if you haven't picked that up on that already. So he has this personality, and I recognize it in Dr. Key as well. And I've kind of said this before that I'm afraid that there's just this unique kind of personality, a Cary Herzberg, a Dr. Key, who they need to do more for the patient. They're part of that 20% that Dr. Herzberg was talking about. And I'm wondering if ophthalmologists are suffering from kind of the same problem. Dr. Key, do you find them, dabbling or not? And like, how are we going to get them to go all in if not?
I think it's not a priority. That's the main issue. If it's not a priority, they're not going to allocate time and energy into myopia management. And I think it's to make it a priority, it's education and communication. Yeah. And
Dr. Herzberg, do you agree with that?
I do. I think you have to, work through that to prioritize how you're, as I say, with the patient, a pediatric patient, you're getting, that kind of input into that, where you're putting your focus on that. Your staff is putting your focus on that. Your office is prioritizing that. And I think that, we start with the schools, really, when you're talking about optometry. You really have to begin in the school to really bring myopia management to, up and educate on it. And I was kind of, Dr. Key was saying that he had this brief encounter with OrthoK in school. Well, it's not so much different in optometry school either. It's not too much different. The two professions have a similar, exposure to that. So that has to, that for the case of myopia management, that has to change.
Definitely. All right. So we're going to take a couple of questions. So if you have a question for our panelists, please put it in the chat or the Q&A before we switch over to our clinical corner. And we have a question right here. It says, best way to track efficacy over time, axial length and myopia power progression with intervention versus without. Cary, what do you think?
Axial length is it's transformed my practice. If you don't have that ability, for instance, you can't, atropine, it's just, it'll mask the axial length changes. If you're just doing refractive data. So you gotta do it. But I use it totally in my practice now, and I use atropine, low dose atropine quite a bit too, with either multifocal soft lenses or with the OrthoK fits. And you can just bring those patients in, adjust the dosage if you want, or else even change the OrthoK design effectively. So it makes you into it puts you at another level on your care.
And Dr. Key, anything to add?
Yeah, I totally agree. I think now we're doing axial length every 6 to 12 months on our patients. I think I just started doing that, so I'm not as familiar with that as Dr. Herzberg, but I think that it's a perfect tool, other than just stopping the OrthoK every 12 months for a month, which is not practical.
Yeah, we're dealing in microns now. Right. I mean, this is amazing, right? Is this amazing? I have to educate my patients, bring up the power. It says, we're dealing with microns. I said, so the patient usually comes in and they think there's this, they're going to press this eye down with an OrthoK lens. I mean, it's like a press, a physical press. And I have to tell them, hold off, back off a minute. We're talking about 8 to 15 microns. And a piece of his hair is 70 microns thick. So that's how small it is. So this axial length measurements in microns allows me to be preventive care, because I can see the change before it's refractive, before there's a refractive change.
Right.
So, yeah.
All right. Okay. So we're going to switch to the clinical corner in just a second, but I want to ask one last question while we give people an opportunity to put any remaining questions in the chat. Dr. Key, through the AAOMC, I've encountered a number of optometrists who work for ophthalmologists. And when I ask them if they do myopia management, they say, well, I'd like to, but the ophthalmologists I work for, they don't want to let me do it. So I'm going to put you on the spot here. Can you give these optometrists some advice about how to approach their ophthalmologists? Like, what do they need to focus on, and how can they convince them that myopia management is right for their practice?
Well, that's a really hard question. Thanks for asking that.
Yeah, for sure.
I mean, I think any kind of optometrist or ophthalmologist, we kind of have a little bit of an ego problem. So yeah, I think that, you know what, the best way for an ophthalmologist to be more receptive of OrthoK or other aspects of myopia management is talking to another ophthalmologist who's familiar with OrthoK or myopia management. So I think, you know, right now, there are resources on the AAO website about myopia management, and to refer to that, because, you know, to them, it's like, yeah, it's like, you know, I don't know any analogies, but it's like, you know, one group, you know, Chinese people making rice and Korean people making rice. You're not going to ask one, you know, and critique the other. You're going to ask another Chinese person how to make a rice if you're Chinese, you know. So the same thing with myopia management. They have to get their resources from another ophthalmologist until the time comes when we can speak freely to each other. It's just going to be like that.
All right, well said. I'm sorry for putting you on the spot like that. All right. So if either of you don't have anything else to add, it doesn't look like we have any more questions to come through. So we'll go switch it over to our clinical corner. So we'll have our panelists turn off their cameras and microphones, and then I will introduce Leah Johnson and Mark Cosgrove. All right, so first off, Dr. Leah Johnson is one of the industry's top global leaders in myopia management. She works with key opinion leaders and eye care professionals to bring a better understanding of myopia and treatment options that enhance patient outcomes and care. And in 2021, she was recognized by Vision Monday as one of the most influential women in the optical industry. And Mark Cosgrove is considered an expert in the field of orthokeratology by his peers. For 25 years, Mark has trained thousands of ECPs globally on how to achieve success utilizing OrthoK and myopia management, and has documented success with some of the most visually challenging patients. All right, take it away.
Thank you, Matt. And
thanks,
let
Matt.
me share my screen here. All right, so as Matt had mentioned, we are part of CooperVision Specialty Eye Care, and we are going to discuss with you all today on our OrthoK portfolio. So with this, I'm going to hand it over to Mark.
Thanks, Leah. So here at GP Specialists, we have one of the world's largest portfolios of OrthoK lens designs. We carry 4 different designs, and I'm going to get into each of them just briefly right now. And then Leah and I will hit on a couple of them throughout this clinical corner. So first, our in-house design, it's the IC. It's manufactured by GP Specialists, and it's our in-house design. It's a fully customizable design that we can change in as little as 1/8 of a diopter step. And we have a new myopia management profile that we put on the lens to maximize peripheral defocus. Our second lens I'll talk about is the GOV. GOV, we are the U.S. manufacturer and distributor for the GOV designs. They are by Dr. Arthur Tung. The GOV designs are for your harder to fit patients, your higher myopes, flatter corneas. Those types of patients are really good in the GOV lens designs. We are also the U.S. manufacturer and distributor for the OrthoTool lens designs. That's a computer-assisted design software by Dr. Eddie Chow out of Canada. And again, we're his U.S. manufacturer and distributor of that. And last but not least, we are a distributor of the Paragon CRT lens. Paragon CRT is the gold standard in OrthoK, still is the gold standard in OrthoK. And with that, I'm going to let Leah tell you a little bit more about Paragon CRT.
Thank you, Mark. Yes, so with Paragon CRT, you know, why use Paragon CRT as an OrthoK tool in your myopia management toolbox? And the first reason is that it's really easy to learn. And we know that, you know, with the Paragon CRT lens design, we really have 3 standard parameters. We have the central base curve, which is the treatment zone to correct the level amount of myopia. We have the return zone depth, which is this dark purple portion of the lens. You can see it highlighted with the fluorescein underneath, as well as the lens on eye. And this is the return return zone depth, helps with centration. And then our third parameter is the landing zone angle. So if you're just getting started with OrthoK, it's a very nice and simple lens to learn how to change the parameters. And then as you become more advanced and more familiar in fitting OrthoK, we have more customizable options with the Paragon CRT dual axis design. And so with this design, you now can fit patients with higher levels of corneal toricity. We now have, 2 different return zone depths and the 2 different meridians, vertical and horizontal, and 2 different landing zone angles to help control the landing zone or the edge lift for patients even with more limbus to limbus toricity. And so with CRT, it's also very easy to calculate your initial lens. You can actually use your smartphone right now to scan the QR code to download these lens apps, and this will help you. And so here's a little demonstration of the Paragon CRT lens. And when we go to the app, you can easily calculate your patient's parameters. So say, for example, this patient is a -2. You would actually then input their flat Ks and their steep K values. You can get this off of your auto refractor or a topographer. You would want to put the patient's visible iris diameter for their corneal diameter size. You can customize by using, different optic zones, 5mm or 6mm, depending on your patient's needs. So we can customize all of this, your patient's, tint color, lens color of choice, warranty, everything like this. And you can actually just then send in your order. And so the calculator will tell you your lens parameters that you need. If you have diagnostic lenses, you can place that lens right on the patient's eye that very day, or you can also empirically order the lens. So another reason on why CRT is that we're very transparent with our parameters. And so with Paragon CRT lenses, all of the lens parameters are laser marked or etched inside of the lens for easy identification. For patients who maybe are siblings and you want to make sure that they don't get their lenses mixed up, you can make sure and ensure that they're wearing the correct parameters. Really helpful for any troubleshooting as well, to make sure they're not wearing an older pair of lens or so forth. And so this is an example of what the lens looks like on the eye. And then lastly, why use Paragon CRT is for immediate dispensability. And so with Paragon CRT, we have multiple options. You can order empirically, and that's perfectly fine, but you can also invest in a diagnostic set and immediately put on a lens on your patient that day. And this is great for that highly motivated patient that comes in your practice. They're ready to get started with OrthoK. And so you can show them the benefits of this, in your practice, and have them come back the next day for that one day, wow factor when they take off the lenses. And so this benefits you. You have that initial dispense, that 1-day follow-up, the 1-week follow-up, 1-month follow-up, 3-month follow-up. So with this immediate dispensability, you're saving yourself some chair time, because if you need to make any initial parameter changes, you can just go right back to that diagnostic set, make your parameter changes, and then place the lens on the patient for them to have follow-up. And you don't need to wait for that 1 week or so for the lens to be custom made and ordered and shipped to your patient. And so the benefit to your patient, they get the immediate effect the very next day that they're able to start seeing clearly. And so with that, I'm going to pass it back over to Mark to share with you on, why use other lenses such as IC by GP specialist for your patients.
Perfect. Thanks, Leah. So why use IC when, she just gave such a great demonstration of why you would use Paragon CRT? Well, if any good doctor out there knows who's doing a lot of myopia management, myopia in their office, they know that no one lens design works for everyone. So what we've done at GP Specialists, we offer a large array of designs, and the IC is a fully customizable design. And what I mean by fully customizable is optic zone, return zone, alignment zone, peripheral zone. All of these different zones can be changed in as little as an 1/8 of a diopter step, or 0.1 millimeter on the OZ or on the diameter, so that's a truly customized lens. Can you go to the next slide for me, Leah? So where our lens differs in CRT is the CRT has those 3 curves. You learn those 3 curves, you've learned the design. Ours is very similar, but we have 4. We have still the central base curve, which is your treatment zone. We have a return zone, which is what's creating that peripheral defocus and also where that cornea is moving into. We have our alignment zone. That's where the lens lands, and that controls centration of the lens. And the last curve is our peripheral curve, which provides the edge lift, so we get good tear exchange under that lens. The only other thing that we really push at GP Specialized with the customized is the diameter. We like to fit 95% of the HVID, so we like to know what that HVID is. Putting a fitting set lens on the eye and taking a quick picture or video really helps as well. So a new thing we're coming out with the IC lens is, Leah spoke about the transparent lens parameters with CRT. Well, IC has proprietary lens parameters that we've hidden for years. It's what makes our lens different than everyone else, but we want to have the doctor have more control over those zones. So what we did is we came up with a new myopia management profile that can maximize or minimize the amount of peripheral defocus you want based on your patient's needs. So if you have an adult who is a low myope, gets glare and halos, you can maximize the optic zone to minimize those glare and halos, but maximize your correction. If you have on the other end of the spectrum, you have a patient who is 8 years old, he's a -5 right now, and mom and dad are already -7 and 8 or -9 and 10. That's a kid where we want to really maximize the myopia management and maximize that zone to get maximum peripheral defocus. So as you can see with our lens, if you look at the return zone on these pictures, the one on, if you're looking at the screen, the one on the right, you see there's even that bubble in the return zone. You're like, wow, that's a lot of pooling in there. It looks really steep. And with a lot of lens designs, you might say, you know what, maybe that's not the lens design for me. But a couple things are going on. You have a lot of lid interaction on that. And when you remove the lid, which is creating a lot of those bubbles go away or they move around. The other thing that'll happen is as the cornea reshapes and the return zone in the epithelial cells move into that return zone, those air bubbles will go away. So don't be scared by those air bubbles first day. If the lens is centered, looks good on the eye, send them home that first night, because we're really trying to maximize our peripheral defocus in that zone.
And with that, do we have any other questions on any of our lens designs? See anyone coming up for Q&A here?
Hi, Dr. Marie.
I have a question from Sal Jivraj. What's the max cell?
Sill.
Oh,
Usually half of the myopia. So half of the myopia is usually what we can correct by. I think it's up to 175.
Yeah, Paragon is FDA approved, 6 diopters of myopia, 1.75 diopters of cylinder. We have another question. Paul is asking, how often do these lenses need to be refit? I guess it depends on, once you have a great centered lens, that's working well, we recommend.
It depends on the patient at that point.
Yeah, I was going to say, is their prescription changing? Some prescriptions do change over time. The lenses themselves, we recommend are replaced, yearly. But depending on if the prescription doesn't change, you can just reorder a new lens.
Yeah.
We have another question. Ortho tool for above 2 diopters of SIL. Mark, what are your thoughts on that?
Ortho tool currently does allow you the option to design lenses with more than 2 diopters of SIL. It depends on the patient, depends on the doctor. It's really tough to fit those patients and to get them happy. But ortho tool would be your best bet because you're designing the lens. You're the doctor designing the lens. None of our lens designs are approved for more than that 175 sil. So if you got above that, ortho tool is probably your best bet.
And just something to note, I've noticed a lot of my patients, even though they have residual sil that we can refract for, they actually have a lot better vision than you would expect from someone who doesn't have ortho-K. And so I've been learning a lot about some of these higher order aberrations and how they cancel each other out after ortho-K. And that's another reason on why patients are able to see a lot better than you would expect post ortho-K, even though they have refractive still measured in their prescription. But they're still, you'll see them reading 20/25, 20/30 with a significant amount of uncorrected sil. We have one more question. Is it possible to have toric base curve for the IC lens?
It is. I have on multiple occasions made lenses that have toric base curves. It's not something that we do standard, and it's very rare that we can't get rid of that sil in other ways. But there definitely has been occasions, and that's just another point as to how customizable that lens is, that, yeah, we can do a toric base curve if need be on that lens.
Okay, sorry. And we have someone else says that nowadays there are so many commercial lenses. According to your experience, what lens factors or specifications should we consider in choosing an ortho-K lens for a patient? So that's an interesting question. We have a large portfolio of 4 different lenses, and when do we, prescribe each lens for the patient? Like the short answer sometimes is I look at the K values and the level of myopia. If it is a what I consider, a standard, nice, easy patient, flat K of 42 to 44, myopia less than -4. My first go-to is a Paragon CRT lens. For patients who are more complex and may need a more customized or complex lens design to fit their needs, IC, GOV, ortho tool would go towards those. Not sure if you have anything else to add there, Mark.
I would just agree. It depends on the patient. We kind of discussed it a little bit earlier, flatter Ks, higher myopes, we go more towards GOV. The standard that you can pull out of a dispensing set would be CRT. And then you're, tougher to fit patients where you might have to do some torics or make some adjustments based off of high eccentricity values on the cornea or large HVIDs or small HVIDs, things of that nature, large pupils, small pupils. That's something that the IC can accommodate right out the gate without having to fit a lens with a larger optic zone on a patient or a smaller optic zone on a patient and realize you're getting tons of glare and halos. You can use an IC lens, and we can, instead of being a 5.0 or a 6.0, you can have a 5.5 and go in between, or a 5.2 or a 5.4 to maximize that patient's myopia management as well as their vision.
Or Mark, you can even go larger to a 6.2 or 6.4 for those patients who, are adults, may have larger pupils, driving at night, and need a little bit of a larger optic zone.
We've made them as large as 7.6 optic zones.
There you go. Yeah. Everyone, thank you so much for your time. And thank you for coming here to learn about how we can share pediatric myopia between optometrist and ophthalmologist. I'll hand it back over to you, Matt.
Thanks so much for having us, Matt. Yeah.
All right. Thank you both. All right. Well, that's it for this episode of the knowns and unknowns of myopia management and other cool stuff in optometry. Be sure to join us next month for our final episode in the series, where we'll be discussing pearls for pediatric myopia management. And if you like what we're doing with this series, please make your way to AAOMC.org and consider becoming a full member of the American Academy of Orthokeratology and Myopia Control. Our full members give their actual real-life money to keep our mission alive and to produce content like this. So I'd like to thank Doctors Key, Herzberg, and Johnson, and of course, Mark Cosgrove. I'd also like to thank GP Specialists and Contact for their support of this program. And for all of our listeners and viewers around the world, thank you for your attention, and we'll see you at the next one.